neuromuscular junction. What is neuromuscular junction? It is present between synapse and muscle. Synapse कयो? Which synapse? કેમ સાયલેન્ટ મોડમાં જતા રહ્યા છો? I know this is afternoon lecture. It is difficult to concentrate after food and with filled stomach.
Sir, chemical synapse.
Chemical synapse. Chemical synapse means?
Sir, neurotransmitter release होते हैं.
Okay. Neurotransmitter release होते हैं. So here, what do you understand based on this neuromuscular junction जो आपने शॉर्ट नोट लिखी है, उसमें क्या समझ में आया है? ભાઈ તમે શોર્ટ નોટ લખી છે, તમે સબમિટ કર્યું છે, તો પણ કોઈ જવાબ નહીં.
सर, न्यूरोमस्कुलर जंक्शन पे नहीं लिखी है.
क्या लिखा है तो?
सब स्केलेटल मसल रिलैक्सेंट से जुड़े हुए ड्रग्स की क्लासिफिकेशन के
क्या
बारे
है
में.
वो?
सर, जैसे डीपोलराइजिंग ब्लॉकर्स और उन सब का मैकेनिज्म ऑफ एक्शन और वो सब लिखा है.
That is why I am starting with the neuromuscular junction. What is NMJ? Neuromuscular junction. जैसे यहाँ पे आयुषी ने जवाब दिया है प्रेजेंट बिटवीन साइनेप्स एंड मसल, देन साइनेप्स फ्रॉम द न्यूरोट्रांसमीटर विल रिलीज. इसीलिए मैं यहीं से स्टार्ट करता हूं, बिकॉज द चैप्टर टाइटल इज ऑल्सो ड्रग एक्टिंग ऑन न्यूरोमस्कुलर जंक्शन. Okay, instead of wasting time in questioning, I will come to the point and I will start my discussion, because I don't think that this interaction will be good enough, because poor response from the audience side. Few students are only replying. So let us discuss about the drug acting on the neuromuscular junction. So basic, as I discussed earlier also, that here this is the junction. Basically it is the junction between neuron and muscles. As you told rightly that it is a gap or synapse or chemical transmission have take place in this region, because this is the neuron from where neurotransmitter is going to release, and it will be releasing in this synapse, and that will be acting on the muscles or receptors present on the muscles, and it will produce the response. So today we are going to discuss on these drugs acting on the neuromuscular junction. Earlier this was used for the hunting purpose, and it was applied on the tip of the arrow during ancient time. वो लोग क्या करते थे? They were applying on the tip. of the arrow, and this arrow was used for the hunting purpose. This arrow will be acting on the muscle of the animal, and this muscle or animal will be paralyzed, and after that they will be cutting this animal and they were using this for the eating purpose. So this was used in the ancient time, and this is famously known as a arrow poisoning experiment. It is famously or known as a arrow poisoning, and later it was known that this compound is the D-tubocurarine, DTC. It is abbreviated as DTC, D-tubocurarine. मैं जनरली जब भी ये टॉपिक डिस्कस करता हूँ तब ये पॉइंट डिस्कस करता हूँ दैट दिस एंसेस्टर वर यूजिंग दिस DTC for the purpose of hunting, and today even with the advanced technology still we are facing a difficulty in research with so many advanced technology. So who is following whom? Were they were more forwarded, or today we are more in the advanced culture? That is the question of the debate. Another question I used to ask during this topic, that DTC, if this causes muscle relaxation of the animal, then if this person is eating this animal, why these muscles are not getting relaxed? The person who is eating, वो खाता है, उसका क्यों relaxation नहीं होता? So the first thing in the answer part, that this DTC is a common quaternary ammonium compound, and this quaternary ammonium compound that does not absorb from the GI tract. That is why the muscles are not getting relaxed. And another thing, in the GI tract there is a smooth muscle, while this is the skeletal muscle which we are discussing. So different target. And as we know that in the skeletal muscle, that receptors are nicotinic cholinergic receptors. So once this acetylcholine is released from this neuron by the process of exocytosis, this acetylcholine is going to bind on this nicotinic cholinergic receptor, and based on that it will produce the depolarization, and because of that it will lead to the skeletal muscle contraction. This is the procedure or effect of this released acetylcholine on the skeletal muscle. Means what we can understand, that this is the effect of acetylcholine on the neuromuscular junction. This released acetylcholine is producing a skeletal muscle contraction by the nicotinic cholinergic receptor acetylcholine interaction. Means acetylcholine is producing skeletal muscle contraction. Now let us discuss in detail that this, if we want to deal with the drug, also this side, that the drug will be either acting by alteration, I am not saying that decrease, increase, it is alter, change, increase or decrease, it may be based on the drug. So alter the acetylcholine release, or it will alter the metabolism. So here either we will deal with this acetylcholine metabolism, that this acetylcholine is going to metabolize, and based on this metabolism, if the acetylcholine is metabolized, acetylcholine level will go down. If we inhibit this metabolism, then acetylcholine level will increase. So either we are dealing with its metabolism, or we are altering the acetylcholine release. Either we will increase the acetylcholine release or decrease the acetylcholine release. That is why we are using the word alter. Here drug, there are some examples that drug which increase the acetylcholine release. These are the examples. They will produce the larger amplitude. Drug which decrease the acetylcholine release, like botulinum toxin, they will inhibit this metabolism of acetylcholine and prolong the response again with larger amplitude. Here, in contrast, drug which block the ion channel will decrease amplitude and duration of response, while drug which block binding side, these are the two different things. One is the blocking of the ion channel, another is the blocking the binding side. Like example is alpha bungarotoxin, that will produce the smaller amplitude of response. Another thing that commonly known agent, that nicotine. Nicotine is the agonist at the site, and here the receptors, as we discussed earlier also, the receptor present in the skeletal muscles are nicotinic receptors. So here the nicotinic receptors is sorry, on the neuromuscular junction, they will respond to the acetylcholine and nicotine. These are the agonists for these sites. This nicotinic agonist, they increase the permeability. This nicotinic receptor agonist, they will increase the permeability of the sodium and potassium. So this will increase the permeability of the sodium and potassium, and that is why they will lead to the depolarization. So here, based on this sodium potassium permeability, its level, it will produce varied degree of the depolarization. Here, the first word that you may come across, that is the fasciculation, that is the twitching of the muscles, that is because of this depolarization. It is known as a fasciculation. And another word, that is the flaccid paralysis. These are the two new words, maybe new at your end. The one thing, that is the fasciculation, that is the twitching of the muscle because of this depolarization, and another is the later, it will lead to the flaccid paralysis. It is loss of the muscle tone, that is the flaccid paralysis, can produce by a depolarizing agent. The example, as I told you earlier, that nicotine is the agonist, so it will produce the rapid depolarization block. Be careful, इसको ऐसे याद रखना है कि किसी को फेंकना है अपने, तो उसको हाइट पे ले जाएंगे and then we'll throw it. So basically this blockage is because of the depolarization. मतलब ये पहले क्या करेगा, it will act like agonist, it will produce the depolarization and then it will produce the block. So depolarization block. So here this is known as a depolarization blockage. जो आगे भी आएगा अपने depolarization blocker as well as non-depolarizing agent. So there will be two category of the agent. एक आएगा depolarizing, another non-depolarizing. So here the depolarization blockage take place. Here there are two categories of the agents are there. One is the neuromuscular blocker and another is the spasmolytic, muscle spasm, that will be taken, like, so that they are termed as a spasmolytic. Here we are going to discuss on this point, that neuromuscular blocker. So that side will be at this neuromuscular junction. So they will block. That category of the agents are known as a neuromuscular blocker. These agents, they are used during surgery and they will provide the muscle relaxation. So major use are muscle relaxation during surgery. While this spasmolytic category of agent, they are acting as a centrally acting muscle relaxant. Generally they are centrally acting muscle relaxant. In that exception is the dantrolene. Dantrolene is devoid of central effects. So just remember this, that site neuromuscular blocker, they are producing a muscle relaxation, and this muscle relaxation, that is to cause the paralysis during surgery. And the spasmolytic, they are centrally acting muscle relaxant. So these two therapeutic classes from this skeletal muscles, drug acting on the skeletal muscles. So first we will discuss about this skeletal muscle relaxant, categorized, that is based on the site as well as the duration of action. So here the site peripherally acting, then directly acting, and third one centrally acting. In that first one, peripherally acting is the depolarizing and non-depolarizing blocker. Now you have to remember these names. मैंने पहले भी exercise दी है. Depolarizing blocker example is the succinylcholine. कुछ जगह पे इसको SCH पे लिखा हुआ है, but we will use this succinylcholine, or it is also known as suxamethonium. Be careful, hexamethonium is different, decamethonium is different. Here pick up the word. This suxamethonium, then decamethonium. This suxamethonium is also known as succinylcholine. These both are same. Succinylcholine or suxamethonium. Another agent from this category is the decamethonium. Then comes the non-depolarizing agent. Non-depolarizing blocker, short acting, मीवाक्यूरियम. यहाँ पे आपको क्यूरियम दिखेगा in the suffix. Short acting मीवा. Intermediate atra, sistra, vacuronium and rocuronium. लॉन्ग एक्टिंग, जो मैंने पहले जहां से स्टार्ट किया है टॉपिक, DTC, डी ट्यूबो क्यूरारिन, देन पानक्यूरोनियम, डोक्साक्यूरियम एंड पाइपरा और पिप्राक्यूरियम, whatever you pronounce. Then directly acting example is the dantrolene and quinine. They are the directly acting skeletal muscle relaxant. Here we discussed earlier that dantrolene. So this is the directly acting, as we have also written that it is devoid of the central effect. So next category is the centrally acting chlorzoxazone. Muscle relaxant अगर कोई नाम देखो तो chlorzoxazone, then cyclobenzaprine. These are the agents belongs to the centrally acting skeletal muscle relaxant. Now first we will discuss about the depolarizing blocker. Here this succinylcholine is a quaternary amine that is having the 10 carbon. Sucsa 10 carbon. This is structurally similar to the acetylcholine. It is produced the depolarizing block. So first it will produce the depolarization block, and then further stimulation will not produce response at the end plate. End plate in the sense here initially it will produce the skeletal muscle contraction by the depolarization, and then it will block. That is why it comes under the category of the depolarizing blocker. Here there are two phases. The one, that is the phase 1, it is known as a depolarizing block, and phase 2, that is known as a desensitization block. Desensitization block. So here the succinylcholine that act as an agonist at the ligand gated channel, and that is why it will increase the permeability of the sodium as well as potassium. So it will increase the permeability of the sodium and potassium and result into the fasciculation. This fasciculation is the twitching of the muscles, and later it will produce the flaccid paralysis. I explained earlier that what is the fasciculation and what is flaccid paralysis. So this flaccid paralysis, that is the phase 1 blockage. This one, phase 1 blockage. You can read this content later for this writing part of this phase 1 blockage, or it is known as a flaccid paralysis. So flaccid paralysis take place. Then we are moving forward towards this desensitization part. So initially it is produced the depolarization and then prolonged depolarization that inactivated. Here there was increased permeability. Now what happened? Prolonged depolarization, मतलब इसको समझना हो ना, आसानी से समझना होता है, ऐसा समझने का कि लेक्चर बहुत लंबा चला तो पहले समझ में आया, कॉन्ट्रैक्शन हुआ और लेटर बहुत लंबा चला तो सब इनएक्टिव हो गया. तो यार initially it is producing the increased permeability and then prolonged depolarization. Because of this prolonged depolarization, here inactivate the sodium and thereby repolarization and producing desensitization. This is known as a phase 2 blockage. So there are two phases: phase 1, that is the depolarization blockage, and phase 2, that is known as a desensitization blockage. And this two, after this, as we are using this for the paralysis purpose, or what purpose we are using this? We are using this for a muscle relaxation during surgery. So here the later after surgery, as we are using for this operation or surgery purpose, but after completion of this, it will result into the post-operative muscle pain. So later it is going to produce a post-operative muscle pain. And here, because of this increased permeability, it is resulting into the hyperkalemia. Just remember this word, hyperkalemia. It is also going to become in the next upcoming slides. So hyperkalemia, and that is producing the arrhythmia. So hyperkalemia and arrhythmia. Just remember this. So here the depolarization blocker like succinylcholine, or it is also known as succinylcholine, succinylcholine, or it is also known as a succinylcholine, having two phases: the phase 1 depolarization and phase 2 desensitization blockage. Regarding some points related to this succinylcholine that is rapidly hydrolyzed by the plasma cholinesterase, and that is why it is administered by IM or IV route, intramuscular or intravenous route. This succinylcholine is also going to be metabolized by the pseudo, or this, it is also known as a butyrylcholinesterase enzyme in the serum. Regarding onset, the succinylcholine that produces the rapid onset and short duration of paralysis. This may prolong, or this either we can say this will prolong in the case of the genetic defect. If the patient is having the genetic defect in either cholinesterase, pseudocholinesterase or butyrylcholinesterase activity, and because of this the prolonged paralysis will occur, because here there will be slowing of the metabolism of succinylcholine and acetylcholine, and that is why it results into the prolonged paralysis if the patient is having the genetic defect. Regarding the blood-brain barrier crosses, the succinylcholine does not cross the blood-brain barrier as well as the placental barrier. Succinylcholine can cause cardiac arrhythmia because of the hyperkalemia. So these are the points related to the succinylcholine. Now clinical use. Clinical use is the succinylcholine is administered to produce flaccid paralysis with rapid and ultra short action. The action that is the less than 1 minute and with the duration that is 10 minutes. So onset is less than within 1 minute and duration 10 minutes. This is used to produce flaccid paralysis. During the procedure, it is known as a RSI or RSI, that is rapid sequential intubation, or it is endotracheal intubation, as well as the to produce the muscle relaxation during surgery. That is the major clinical uses of the succinylcholine. Adverse effect, as I told you earlier, it is going to result in the hyperkalemia, as well as it will also increase the IOP, intraocular pressure. Another adverse effect is the myoglobinuria, as well as this is also adverse effect that after surgery or after its therapeutic indication, it is going to produce the muscle pain. So after surgery, post-operative muscle pain, that is also one of the adverse effect of this succinylcholine. So this was about the depolarizing blocker. Then now moving forwards, the non-depolarizing blocker. As I told you that the non-depolarizing blocker, just let us revise the classification part. The depolarizing blocker and non-depolarizing blocker. So we have completed this depolarizing blocker. Now we are moving towards this non-depolarizing blocker like mivacurium, atracurium, DTC. So this DTC is a prototype, means we can say that this is the leader of this group, non-depolarizing blockers, DTC. As the name non-depolarizing, here it will not produce the depolarization block. It is non-depolarizing blocker, and we already discussed that it was used for the error poisoning. Leader is the DTC, and another agents from this class are atracurium, mivacurium, pancuronium, vecuronium, rocuronium, rapacuronium. And if you want to write down based on the duration of action, so you can write down this classification: short acting, intermediate, long acting agents. Regarding the mechanism of action, as these agents are non-depolarizing blocker. So all these agents, they are competitive neuromuscular blocking drug. There is a competition for the binding. Competitive neuromuscular blocking agents, they are act by blocking the ACH side. What they will do? They will block the ACH binding side. And in comparison with this, they are reversible. They are reversible competitive binding agents or competitive antagonists at the neuromuscular side. So reversible blocking. And that is why what they will do, they will inhibit the excitation. Inhibit the excitation of end plate cholinergic receptors. I repeat, this was discussed in earlier slide. This slide, that released acetylcholine will bind with this nicotinic receptors and going to produce the depolarization, and that is why they are producing the skeletal muscle contraction. So here what they will do, These agents, they are competitive blocker for this binding site. So that is why they will inhibit this excitation of end plate cholinergic receptor. As they are reversible, as well as because of this reversal of action, if you want to reverse this, they are reversible, but if you want to produce the reversible effect immediately, then what you will do here, you can increase the acetylcholine concentration. As we know that competitive antagonism, here if the competitive antagonism, if we increase the concentration or dose of the agonist, we can have the maximum response, as well as the reversal can be achieved. So here what we can do, we will inhibit this metabolizing enzyme, that cholinesterase enzyme. We will inhibit this cholinesterase enzyme, and by that way we will increase the acetylcholine level. As this drug, this non-depolarizing blocker, they are competitive for side. If we increase the acetylcholine concentration, we can have this reversal of this effect. So this reversal of action of non-depolarizing blocker can be achieved by anticholinesterase. While if you look earlier, that this binding site here, it is going to act that acetylcholine binding will be competitively inhibited. Here we are using the non-depolarizing blocker. That non-depolarizing blocker will bind with this side, and because of that the acetylcholine binding will not be achieved, and that is why this end plate response is inhibited. So skeletal muscle contraction will be inhibited. So that is why this agent that belongs to the non-depolarizing agent or competitive agents, they are competitively binding at this side. In addition to this DTC that lowers the blood pressure by ganglionic blockage of the nicotinic receptor, as well as that is also producing the histamine block. Here just try to cover this point of hexamethonium. If you read, I think it is in the Goodman and Gilman, if you read, there is a story that is hexamethonium men. Here if we block this ganglia, because of the blockage of the ganglia, here the ganglia is blockage, and as we know that ganglia in the both, if you block the ganglia, the both systems, the sympathetic as well as parasympathetic system will be blocked. Now think about the situation. If you block this ganglia, then just read out that story of the hexamethonium men. Hexamethonium, that is the ganglion blocking agent, hexamethonium. If you block this ganglia, then both the pathways, sympathetic as well as the parasympathetic pathways, will be inhibited. And just read out that story, hexamethonium man. This person will have the no sweating. You block kare, no sweating will be there. And just remember that sweating, that is through the sympathetic nervous system, but neurotransmitter released at the sweat gland or at the postganglion nerve ending is the acetylcholine. So if we block this, so this hexamethonium man will have no sweating, उसका कॉलर जो है वो भी व्हाइट ही रहेगा, मतलब कोई स्वेटिंग नहीं है। देन उसके सॉक्स जो है उसमें से कहीं भी बदबू नहीं आएगी। विल हैव द ड्राई आईज, नो सिक्रीशन। So just read that story. It is very interesting story. It is narrated very well that as a hexamethonium man. Coming back this DTC, that is lowering the blood pressure by blocking this ganglia, and pancurinium that increases the heart rate and blood pressure. Basically, this is by the vagal block. Here, vagal block. Vagus now that is mixed in nature, but dominant is the parasympathetic. And here, if we block this parasympathetic, just remember the statement: parasympathetic nervous system is having inhibitory effect on the heart and blood vessel. So here, if we block this vagal block or vagal system, that will produce the blockage of this parasympathetic, and that is why vagal block will produce increased heart rate and blood pressure. So pancuronium, that is increasing the heart rate and blood pressure. While this cardiovascular effects, or rather we will use the cardiovascular adverse effect, they are minimum with these other agents. They are the vecuronium, picrocurium, then doxacurium, cistacurium, as well as the rocuronium. This cardiovascular effects are less with this category of the agents. So pharmacological actions of this DTC that produces the relaxation in following order, like it initially relaxes the head and neck muscle, and then limb, then finally the muscles of the respiration. And this recovery will be in reverse order: skeletal, this respiratory muscle, limb, then head and neck. So reversal will be in reverse order. So DTC will produce the muscle relaxation. Then clinical uses, as I told you, that it is used to induce the neuromuscular blockage. When we will use this? For the surgical procedure. So induction of the neuromuscular blockage. So non-depolarizing blockers are used to relax the skeletal muscle in facilitating surgical procedures like intra-abdominal or intrathoracic surgery. But here again, be careful that when the patient is of the myasthenia gravis, in this myasthenia gravis patient, there will be less number of the cholinergic receptors. So because of this less number of the cholinergic receptors, less functional cholinergic receptor at the end plate, that is in the case of the myasthenia gravis. So because of this less number of the receptor, here this DTC that belongs to the category of the non-depolarizing blocker, they will be acting as a competitive. So here what happened? If the patient is of the myasthenia gravis, that patient will be more sensitive to produce the paralysis, because here less number of the functional cholinergic receptors. So that is why the patient with the myasthenia gravis are more sensitive to the paralysis by DTC. So that is why we have to go for the dose adjustment, and close monitoring is also required. Otherwise, it will result into the more or severe respiratory paralysis and death thereafter. Another, that is the mechanical ventilation. The example are the category of the pancuronium, atracurium, like that. They are used in the endotracheal intubation, जिसको मैंने आगे बताया आपको. One procedure is there, RSI, rapid sequential intubation. which you will study in fourth year toxicology part. So RSI, rapid sequential intubation. So these agents are used for the endotracheal intubation. They will produce the mechanically ventilated patients to induce paralysis. So in that case, for the induction, or they are used as a inducing agent or induction of the paralysis. Two categories are there in RSI, inducing as well as the paralyzing agents. So these agents are used as a paralyzing agent. So they will induce the paralysis. These are the dose related points, and they will produce the action within 2 to 3 minutes. Again, dose adjustment is required for the renal or hepatic dysfunction. Regarding adverse effects, they are going to produce the prolonged paralysis. Cardiovascular and muscular adverse effects are there, as well as they are also going to produce the histamine release, and that is why we may need the antihistaminics. If there is a histamine release or allergic reaction is there, then to counter this, we will need a treatment with antihistaminics. So this was about the depolarizing as well as non-depolarizing. This is just a brief summary table, that non-depolarizing blocker as well as the depolarizing blocker. Depolarizing blocker example or leading agent succinylcholine, here DTC. They are going to produce the flaccid paralysis, while this depolarizing agent initially they will produce the contraction, fasciculation, followed by flaccid paralysis. That is why they are known as a depolarizing blocker. Two phases, phase 1, phase 2 block. Then paralysis sequence of non-depolarizing agent: finger, eye, limb, neck, face, tongue, and then respiration. Here neck, limb, face, pharynx, then respiratory. Effect with neostigmine. This is the cholinesterase inhibitor. As we know that non-depolarizing agent reversal points we have discussed here. Reversible, that can be achieved by the anticholinesterase. So here this can be blocked, or antagonism can be achieved by this neostigmine, which is the example of the cholinesterase inhibitor. While here no effect with in case of the non-depolarizing agent. Effect with the other NMJ, neuromuscular blocking agents, neuromuscular junction blocker. If it is non-depolarizing agent, then effect decrease, while here depolarizing increase. Effect on histamine release. Regarding the non-depolarizing agent, just we have discussed that histamine release, and we are going to use this antihistaminic, while in case of the depolarizing it is stress, and in case of the non-depolarizing agent it is significant because of this histamine release. And if it is so, then we need to use the antihistaminic. So this is about the depolarizing and non-depolarizing agent. Any question? Just go through this point.